Picture a pie, a huge pie. That's the entire US economy.
The whole gross domestic product.
Every car sold, every app built, every cup of coffee poured. Now take more than 20% of it.
1/5.
That's where US healthcare spending is projected to be by 2034, nearly $9 trillion.
And today we're walking through a leaked market intelligence brief, the SWFT brief for the week ending June 29th, 2026, to see who's fighting to control that slice.
It's a battleground. Antitrust suits, policy shifts, regulatory pressure. And just to be clear, we don't have a horse in this race.
Right, we're not taking a political side. We're translating the brief so you can see where the pieces are moving.
And the main shift is this. Healthcare used to be regulated mostly around delivery of care.
Doctor-patient interaction, hospital safety, devices.
Now the real fight is over the systems underneath it, payment integrity, drug pricing and rebate flows, digital demand.
If healthcare is a giant reservoir of money, regulators seem to be realizing you can't keep pouring more in if the dam is cracked.
Which brings us to enforcement. The Department of Justice announced the largest healthcare fraud takedown in U.S. history. 455 defendants across 41 federal districts. Alleged fraud exceeding $6.5 billion. More than $127 million seized in assets.
And this wasn't minor sloppiness. They targeted coordinated schemes, fraudulent wound allografts, unnecessary cardiovascular testing, kickback rings, Medicaid billing for services never delivered.
Blatant theft. But the brief also points to a $342 million settlement with Elevance Health over Medicare Advantage billing and diagnosis coding. That's more subtle.
And more structural. In traditional Medicare, payment is tied to each visit or test. In Medicare Advantage, the plan gets a flat monthly payment per patient, but it's risk adjusted.
Meaning the sicker the patient looks on paper, the more the government pays.
Exactly. The allegation was that Elevance mined patient data to add diagnosis codes that weren't actively being treated or weren't entirely accurate to increase those payments.
So coding isn't just clerical work, it's money.
Right. If the DOJ takedown was about plugging obvious leaks, this settlement is about making sure the meter itself isn't rigged.
And the brief suggests enforcement is changing, not just pay and chase years later.
Yes, payment integrity is becoming a core capability. Predictive analytics, AI-driven fraud detection, catching anomalous coding or fraud patterns before claims are paid.
But even if you stop fraud and aggressive coding, you still have a bigger issue. What if the legal structure of the market is built to extract too much money?
That's where the focus on intermediaries comes in, especially PBMs, pharmacy benefit managers.
The PBM trade group, PCMA, is suing Illinois over a transparency law, and Florida's Attorney General is investigating CVS over alleged anti-competitive pharmacy practices.
Most people hear PBM and have no idea what one does. Think of a PBM as a toll booth between drug makers, pharmacies, and the employers or insurers paying the bill. Because they control access to millions of patients, they can demand large rebates from manufacturers in exchange for favorable formulary placement.
And the controversy is where that rebate money goes.
Right. Historically, the PBM may keep part of it rather than passing it through. Then there's spread pricing. Pay the local pharmacy one amount, charge the employer more, keep the difference.
Which is why the brief highlights the LucyRx and Abarca Health merger.
Exactly, a larger, transparent alternative to the traditional PBM model.
But transparency only matters if it changes bargaining power.
That's the point. If an employer can actually see rebate flows and spread pricing, the information asymmetry shrinks. Then they can demand things like 100% pass-through of rebates.
Same leverage fight on the hospital side. The brief mentions Eli Lilly clashing with hospitals over restrictions on 340B contract pharmacy distribution.
The 340B program was meant to help safety net hospitals. They buy drugs at steep discounts, then may dispense them to commercially insured patients and get reimbursed at normal market rates. They're supposed to use that margin to support care for the uninsured.
Over time, hospitals expanded that through outside contract pharmacies, which increased volume and profit.
Manufacturers like Eli Lilly argue that has drifted far beyond the program's original intent. Hospitals say the restrictions threaten their survival and their ability to serve vulnerable communities.
Which is another way of saying both sides are fighting over who keeps the margin on the prescription.
And it doesn't stop there. The DOJ had an antitrust settlement with Ohio Health over physician contracting practices that allegedly reduced competition.
CMS is also recalculating 2026 Medicare Advantage Star Ratings mid-cycle.
Which sounds technical, but a half-star drop can cost an insurer hundreds of millions in bonus payments. The brief says that creates volatility for future reimbursement.
And the Congressional Budget Office is reviewing the No Surprises Act to see how independent dispute resolution affects premiums.
All of this is happening because the buyers in the system have hit a wall. According to Mercer's employer survey in the brief, employers expect healthcare costs to rise 8 to 9% this year.
To offset that, they're shifting more cost to workers through higher deductibles and premiums. And pharmacy is the fastest growing part.
It's not just employer plans. ACA Marketplace enrollment has fallen by nearly 3 million members.
Which is dangerous because when premiums rise, healthier people tend to drop coverage first.
That leaves a sicker risk pool, which drives premiums even higher, which pushes more healthy people out. Classic downward spiral.
And the physical system is straining too. The federal government has a $50 billion rural health transformation fund, and it's pushing rural hospitals to downsize inpatient care just to survive.
So this isn't a temporary inflation problem. It's structural. Employers are running out of room to keep shifting costs.
If you raise a deductible to $10,000, you haven't fixed healthcare costs. You've just handed the problem to the employee.
And then that employee skips care, avoids preventive visits, and eventually lands in a much more expensive crisis. Completely self-defeating.
So what do employers do instead?
Change the purchasing model. Move away from the yearly ritual where HR just accepts another premium increase. Use specialized third-party navigators. Build centers of excellence.
Give me the example.
Knee replacement. Traditional model, local hospital bills $60,000. Employee pays a $5,000 deductible. Insurer pays the rest. Under a center of excellence model, the employer contracts directly with a specialized orthopedic hospital in another state for a bundled rate, say $25,000, covering the whole episode from pre-op through physical therapy.
And the employer can pay for travel, hotel, even bring a spouse, waive the deductible entirely, and still save more than $20,000.
Right. You stop arguing over who pays the inflated bill and start redesigning the care pathway so the bill is smaller and predictable.
But a lot of people don't have access to that kind of plan, so they go looking for alternatives on their own.
Which brings us to digital health and AI. And the surprise in the brief is that tech isn't automatically lowering costs. It may be adding congestion.
The brief cites a study showing patient portal messages rose 153% between 2020 and 2025.
And office visits rose during the same period. So digital messaging isn't replacing in-person care, it's additive work.
Like adding a lane to a highway and getting more traffic.
Exactly, induced demand. Now the clinician has a full clinic plus a flood of portal messages. Helpful for the individual patient, maybe, but system-wide it can become administrative overload.
And without sophisticated AI triage in front of that, it creates more uncompensated labor and more burnout.
If a primary care doctor is spending hours after clinic answering messages, the system starts to fracture.
Meanwhile, patients are turning to AI and social media because ordinary care is expensive and hard to access.
The brief says 3 in 10 adults now use AI or social media for health information.
Which opens up a new risk. If a generic chatbot or influencer becomes your first-line triage, bad advice can delay care and make the eventual problem much worse.
Right, wrong advice on chest pain can end in an ICU stay that is far more dangerous and expensive than a primary care visit would have been.
Then there are wearables and consumer health apps, Oura Rings, Whoop bands, all the rest. They collect deeply personal biometric data,
Heart rate variability, sleep stages, blood oxygen levels. But when a consumer tech company holds that data instead of a clinician, it falls outside traditional HIPAA protections.
So the consumer side is messy. The institutional side is moving fast too. CMS is running a pilot called Wiser to test AI in Medicare prior authorization.
Meaning an algorithm could become part of deciding whether your doctor's recommended treatment gets approved and paid for.
Which could help or hurt.
If it works well, maybe it cuts waiting. If it's poorly tuned, it creates a new automated barrier, denying care based on a model instead of clinical judgment.
So zoom out. We started with a $9 trillion slice of the economy. We've got the DOJ going after $6.5 billion in fraud, regulators pressing PBMs, hospitals and insurers, employers hitting the ceiling on cost shifting, consumers drifting toward portals, AI, wearables, and social media for basic guidance.
And the big takeaway is that cost control is no longer mainly about the physical delivery of care. It's about control systems.
Payment integrity algorithms, drug rebate flows, the digital front door.
Exactly. The next decade belongs to whoever controls those systems.
Which leaves one uncomfortable question. If traditional healthcare becomes too expensive or too hard to reach, and people start relying on chatbots, wearables, and social platforms for their first medical guidance, what happens when that first point of contact is no longer a regulated clinician, but a consumer tech company driven by engagement and advertising?
Then you have to ask, who is really in charge of your health?
That's it for today. Thanks for listening.
We'll catch you next time.